Thank you, Dr. Lay. That was wonderful. We love having him as part of our team because all of those factors, as you know, really affect the overall rehabilitation of a patient with stroke. And I would like to enthusiastically welcome you to the final sessions of the afternoon. I hope you all have enjoyed the conference as much as I have today. And although we spent a lot of time earlier in research and different clinical trials, in the rehab world, we really live clinically. So this last sessions will all not bore you with any statistical p-values, but we will show you real-time treatment of a patient who was managed here on our rehab unit. And I would like to first introduce the team that's going to be presenting with me. I have the honor of working with an amazing group of people, and several of them are presenting today with us. First, I have Victoria Marr, physical therapist, who's worked in the post-stroke population at Houston Methodist for the last 5 years in our inpatient unit. She graduated with her Doctor of Physical Therapy degree from Texas Women's in 2019, and she is also a board-certified neurologic clinical specialist. We have Susan with occupational therapy, who has worked in post-stroke population in Houston for the last 10 years in the inpatient rehab setting. She graduated with her OT degree from KMCH Indian in 1999 and her master's in OT from TNMC in Mumbai in 2002. And she's been at Methodist for the last 12 years, but has been on the rehab unit the last 10. And finally, with speech-language pathology, we have Fala Adnan, who's a speech-language pathologist who's worked in the post-stroke population across many settings. So Fala has been in acute care on our skilled unit on the inpatient rehab for the last 8 years, and she graduated with her master's in communication science and disorders from the University of Houston in 2015, and she's been at Methodist for the last 2 years. And that is my amazing panel that's going to come up and really show you how an actual patient, we often say in rehab, we're kind of the black box. People say, send them to rehab, that's what they need. But then actually what happens to a patient across the street is kind of this mystery. So we're gonna unfold some of that and let a few of our secrets out of the bag. So I will, green button, Dr. Volpe. All right, oh, hold on. So my slides aren't there. Go back. Okay. So I would just like to thank Dr. Chu for eloquently explaining what green means in these slides. And I would like to say one of the things we're really glad to have an opportunity here because for post-stroke rehab, between the insurance payers, it's gotten really hard to get really intensive services for our neurologic patients. So for any of you that are passionate about stroke, treat stroke, we really need to advocate that we have level 1 data for treatment for inpatient rehab, not skilled nursing, not home health, not outpatient, but a brand new stroke is indicated for inpatient rehab to have the best outcomes. So we're going to talk a little bit about a gentleman that came to our rehab unit who was 68, has a past history of hypertension, hypothyroidism, BPH, chronic back pain, depression, had a history of a childhood brain injury that we didn't have much additional information about. He had a left frontal stroke. He was treated with TNK, and he was admitted to rehab about a week after for stroke. And I will tell you all, and I say in the olden days, folks were 2 and 3 and 4 weeks before they came to rehab. Now, day 2 or 3, a brand new stroke patient may be ready to transition to rehab. So we're really getting to folks much sooner. And we often monitored for post-stroke depression when our patients were 2 and 3 months on rehab with us. And now almost all of that, Dr. DeLay, to your point, is outpatient, right? So the acute care folks aren't seeing as much of the post-stroke depression that usually, historically, has occurred about 3 months after stroke. So with that, I turn the floor over to Victoria.
All right, good afternoon, everyone. Like Dr. Caldas said, my colleagues and I are going to be walking you through a patient case that we treated in rehab probably a couple months ago, and hopefully like she said, we're going to reveal some secrets of what happens when you guys manage the patients medically and clear them to go to rehab in the far, far away land of West Pavilion. To help out my speech therapist colleague, who is going to be coming up in a little bit, we're going to test your neurocognitive function at this point in the afternoon and test your ability to recall these words. So try to remember them, and then we'll come back at the very end of all of this. So when we first get a patient over in rehab, our job is to figure out what impairments are we seeing, how is that impacting their ability to do the activities they need to do, and lastly, how is that affecting their role in their life, their ability to get back to their job or to their family or to their whatever is important to them. So obviously with a left-sided stroke, we are expecting right-sided impairments. This gentleman presented with impairments in sensation, coordination, and strength in his right lower extremity. I will note that his upper extremity was much more involved than his lower, so you'll get the perspective from OT next. He did require physical assistance for transfers, so that would be sit to stand, transferring from one surface to another, and he was walking with a walker with assistance when he first came to us. Notably, from our subjective interview, he was previously independent. He was walking community distances with no device anywhere he needed to go. He was also extremely active. He was mountain biking, he was going to the gym to lift weights regularly, he was completing yard work, he lived on a lot of land, and he was also participating in yoga regularly. So all of that goes into our picture of what this patient looked like before the stroke and will help us determine what are our interventions going to look like, what is our plan of care, length of stay, and goals going to look like. So from a PT perspective, we do complete outcome measures with our post-stroke population. We're looking at the domains of balance, walking speed, and walking endurance primarily. As you can see, he was functioning at a fairly high level for someone who does come over to rehab, but overall, compared to his prior level of function, he was at higher risk of falls, not walking quite as well when he came over to us. And the CARE tool, or section GG, is a CMS mandated assessment that we're completing with all patients in rehab, and his score again indicates that he did need physical assist due to balance issues. This predictor tool was published in 2022, and it's pretty cool because we can input some of that information, like the Berg balance score right here, his strength testing for the affected side right here, and it will give us an idea of what our prognosis is for walking function by the time he discharges from inpatient rehab. So as you can see, he had very high numbers populated up here for being able to walk with min assist or contact guard assist by the time he left. And it makes sense because he was very active before, he had the TNK. We're just putting together the picture of knowing that we're going to be working on higher level activities with this patient and expecting a higher level of function by the time he goes home. So when we're determining what our interventions look like for this patient, we're always keeping in mind these principles of neuroplasticity. And I will kind of refer back to this slide as we go through what our treatment plan looked like. When you ask a patient what their goals are for therapy, I would say 95% of the time they're going to mention that they want to walk again. Oftentimes it's them wanting to walk without a walker or without a device. So that brings in the salience piece of what we're looking at for therapy. I think, like Dr. Dulay talked about, apathy is a really big issue with our post-stroke population and their participation in therapy. So we need to be making sure that we're picking activities that are motivating to them. We're getting buy-in from the patient about why therapy is important, and we have to be addressing tasks and goals that are important to them. So one of the big interventions that's being talked about in the stroke rehab physical therapy world is high-intensity gait training. There was a clinical practice guideline published in 2020 that it strongly recommends the use of high-intensity gait training with the post-stroke population. That clinical practice guideline specifically was talking about the chronic stroke population, so post 6 months. But there is more and more emerging evidence to support the feasibility, safety, and efficacy in the subacute population, which is more of what we're seeing in the rehab world. So this is an example of one of our treatment sessions early on. As you can see, He has some deficits in his right foot clearance when he's walking. He has some knee control issues and stance phase of gait. So our goal with this high-intensity gait training is to challenge him, increase the number of repetitions that he's walking and taking steps throughout every session that we're doing, get him working at a high intensity, so we're monitoring heart rate while he's exercising, and we're aiming for him to be working at 70 to 85% of his heart rate max throughout most of a 60-minute session. On the treadmill, we're able to really get more repetitions in again, and we chose an activity to really focus on the specific part of the gait pattern, which is his foot clearance. So he has the card as a physical cue of something to step over. We also have him hooked up to a body weight support system. This was just a way to, as is kind of a safety catch since it was still early on in his stay, but you'll see how we can progress that activity as he gets better with therapy. So in this video, like I talked about, he was very active. He lived on a lot of land, and so he would be, trying to take care of things and be outdoors where the surface is not smooth, even tile all the time. So a way for us to kind of target the specificity of that activity, we set up a bunch of obstacles that are hidden under those mats. So number one, the foam mats on the ground are compliant. They're not just a firm surface. He has to kind of visually scan and see what he's looking at and react to those changes in the surface. And he's also, we're able to progress to changing the direction of his walking. So not only walking forwards, but walking backwards, walking sideways. Now, gait training and high-intensity gait training can look differently depending on the patient and their level of function. This patient was already functioning at a very high level, so we didn't need as much of the body weight support or robotic-assisted devices. This one over here is the Exobionics exoskeleton. We do have one of these in rehab that we can use with our patients who require more support for standing initially. This allows us to get our patients up and walking earlier than we could if we didn't have that and we were just reliant on our hands and bodies to facilitate them. This is the Locomat, which is another robotic-assisted device, again, working on the repetition, the intensity of the activity to maximize the practice and number of steps that they're taking. In the PT world, there's also emerging evidence about the use and efficacy of virtual reality in relation to gait training. We don't currently have any systems, but I know there are talks about figuring out if that's coming in the future. But this is just an example of a setup where you can have a treadmill setup with the screen providing information about an environment that they're moving in. So obviously we're not going to be making our patients walk at that high intensity for 3 hours a day, every day. They will eventually fatigue and we'll have issues in getting them to come back to therapy. So there are other alternative interventions that we are utilizing. This is the functional electrical stimulation bike. We can use this for patients who are weak or who have spasticity, and it can help with neuromuscular reeducation. So a lower extremity session would be a 60-minute session. We can hook up to 6 muscle groups on the affected side, and it's providing them with stimulation to help them be more active and turn those muscles on during that cycle pattern. Most of our patients are spending most of the day either sitting in a wheelchair or in that semi-Fowler's position in bed. And so another great way for us to work on core stability in getting them out of those positions is by working in quadruped and tall kneeling, or even, as you can see, his plank position over there. As a PT working with someone who has more upper extremity involvement rather than lower extremity involvement, I'm also responsible for figuring out how I can incorporate that into our sessions so that on a day where he might have more PT sessions than OT, we're not just forgetting about the arm when we're walking. Those activities can also be very functional, and so you can see in this video, eventually, by the time he discharged, he's able to kind of combine all of that to be able to get himself up off the floor, which is a pretty advanced task for someone post-stroke and that acute after a stroke as well. So this would allow him to, number one, get up off the floor if he experiences a fall, but also get back to his activities like being able to clean the house, get down on the ground to pull weeds, or do his yoga exercises. Now, outside of our individual therapy sessions, we have a large team of people that we work with over in rehab. We have a music therapist and a recreation therapist that we can co-treat with. This is, again, a great way to maybe address the depression side of things or the isolation that people experience when they've been in the hospital for so long. And so it's a good way, again, to make the activities meaningful and a change of pace from the normal one-on-one sessions. So with music therapy, Jonathan, our music therapist, is giving him auditory cues on the pacing, but you can see he's working on a very dynamic activity with no arm support, coordinating arm and leg movements at the same time. We can also do gait training in the hallway. Jonathan will play music and our patient will have to start and stop quickly with the cues from the guitar, or we'll work on changing gait speed or turning and kind of navigating busier areas. And we have a rec therapist who every Friday arranges for some volunteers to bring their dogs for animal-assisted therapy. It's definitely a highlight of everyone's week over there in rehab. And this video is taken from much later on in his stay, and you can kind of see how much he's managing in this video. So not only is he walking on an uneven surface, again, compared to normal flat tile, he's walking right along Main Street where there's a lot of cars passing by, people walking on the sidewalk that can be distractions. He's using his right hand to work on the grasp of the leash. He's paying attention to what Sydney the poodle is doing and making sure that she's following him. And then he's also working on his speech production while engaging with the therapist and the volunteer. So this is a super functional way for us to work on balance and gait training, because it's very rare that when someone goes home, they're walking in a hallway in a straight line. That's just not what real life looks like. And for our patients that we want to get back to independence and back to their activities, it's important for us to consider those variables. We will also arrange community reintegration outings when appropriate. We'll take patients around the hospital or to Rice University or even to the museums, again, to kind of simulate those real world activities. And then we'll also run group therapy sessions that might allow for more social interaction with other patients. Now, I think you've probably gotten the picture that rehab is all about the interdisciplinary team. There's a lot of collaboration between all of the members involved in their care. We meet weekly with most of the team listed here to discuss, barriers to therapy, their progress overall, discharge planning. So it really takes everyone to get these patients ready to eventually go back home. In terms of how we're communicating with our PM&R physician outside of the regular team conferences, from a PT perspective, where we might be looking at spasticity management and kind of communicating back and forth on how the dosage is working or what side effects we might be seeing in our therapy sessions. And then relating back to the high intensity gait training, our patients, we're closely monitoring their vitals throughout those sessions. And if we're having any issues with blood pressure management or something like that, we'll be in contact with them daily about what we need to do going forward. So when it comes to discharge planning, PT is responsible for ordering mobility equipment. Luckily, this patient did not require anything by the time he left. As you can see from that video before, he was walking pretty well without a device, so we didn't need to order anything listed here. More importantly, we had to really consider family training. When this patient and his wife first found out the discharge date that was decided in a team conference, they were very concerned that he was not ready to go home and that he wouldn't be able to manage his day-to-day activities safely because she would be at work during the day and he would be at home by himself. I think part of the problem that happened is it had been a little while since his wife had seen him and seen how well he had been doing in therapy. So the first thing that we did was, send out a message to the whole team so that everyone was aware of their concerns and could address it from their scope of practice. But we also made sure that we reached out to her so that she could come observe some sessions with us and really see how much he had improved in the time that he had been there with us. And we ended up taking this patient out, we were walking around Smith Tower, OPC in West Pavilion. He was running up and down the stairs and the escalators, and by the time she saw that, they were definitely much more comfortable with the plan going forward. We also will provide recommendations on what continued therapy is going to look like after discharge. Our goal for most of our patients, when possible, is to send them home with outpatient therapy. There are many factors that will contribute to that decision, though, so medical status, current level of function, social support will all play a role, and so there are other options that we'll consider as well. So these are the final outcome measure scores. So you can see there were significant differences across the board. Balance, he was no longer at fall risk based on his Berg balance scale, and I also think notably that his 6-minute walk test almost improved to the norm. And this was all done without a device, and that's something that we very rarely see in rehab, but he was kind of the star patient and had the best outcomes that we could have hoped for. And so to end, this is just a video of him walking around the hospital. We took him around to see some of the Christmas decorations before he got to go home. And again, I think his motivation played a really big role in how well he did with his level of participation.